Welcome back to my new video in my channel, and I hope you all are doing okay. And this time I have come with a little, uh, a topic which is uh, quite close to my heart. Uh, Prognostification after the CPCR. Uh, Again, I am going to talk and embark upon this in two videos. Uh, and this is a particular talk which I delivered just recently in the Mahakritikon, uh, which happened in Thane. So, without further ado, let us start with the talk. So this is the document which I referred to for the references, and so when we talk about prognostification, I think it is very crucial, a very sensitive topic. Uh, we need to be very empathetic and also compassionate towards the patient and his relatives, where we need to actually break the bad news. And we will take into account how the neurological assessment is done, and what is the bearing of the hemodynamic stability of that particular patient. And of course, you don't do it earlier to 72 hours. So once the patient, you are very certain that the patient is not doing well, especially in terms of neurological recovery, we need to actually give time of about 72 hours for really having the opinion on the prognostification of this of the patient after the cardiac arrest and the resuscitation. So as we know that CPCR is the vital life-saving intervention which is used for all the cardiac arrest patients, and it is the key decision where the prognostication involves evaluation of whether the patient will survive, what would be the recovery, what is the potential long-term neurological deficits. So it's a complex process, and it will involve so many of the clinical and biological and the biochemical parameters. So the presentation dwells into the critical factors which influence the prognostification, including the neurological assessment, the neurophysiology, biochemical biomarkers, imaging, and of course the cardiac biomarkers. So, why is it important to prognosticate? Of course, as we know, the accurate prognosis will help us in guiding the treatment decision as to whether the further medical aid will be futile or not. It will help us to manage the patient relatives and its expectations, and it will allow us the families which we need to inform about and make the decisions about the end of the life care. And this is another very sensitive aspect. And of course the resources. So once we are certain that this patient's long-term viability is an issue, we will obviously think about the resources which needs to be allotted to that particular patient, and it should not go waste. So these are few of the factors which affect prognostification in terms of the neurological status assessment, the cardiovascular function assessment, whether the patient is hemodynamically stable or unstable, the respiratory status, whether the patient is obviously on mechanical ventilation, what is the FiO2 requirement, whether he is a difficult to ventilate patients, and so on and so forth, and of course the time consideration. So the duration of CPR and the time elapsed between the cardiac arrest, which are significant factor and which have a bearing on the prognosis of that patient. So the time to prognosticate is the initial assessment which we all do in the initial 2 to 4 hours of the event, where we focus mainly on the neurological injury and evaluating the severity of the patient's how the patient has got affected. Of course, when it goes from the days to weeks, of course, there is a continuous monitoring and multiple diagnostic assessments which are done, and the long-term prognosis assessment. So this is probably a very standard way of any intensivist who come across this situation. So definitions of neurological outcomes post cardiac arrest is the cerebral performance categories, or that is called as the CPC, and the CPC 4 is the vegetative state, and the CPC 5 is of course the death. So prognostification in patients with the therapeutic hypothermia and use of sedatives and muscle relaxants. So in both conditions, the use of therapeutic hypothermia and the use of sedatives, there is low clinical reactivity. And the neurological examination, of course, encompasses the examination of the pupils, the corneal reflexes, the doll's eye movement, and of course the whether you have the abnormal corneal reflex, which has a bearing on whether there is a damage to the underlying trigeminal, facial, or both the nerves, and it can be affected by either a stroke or a trauma or a severe brain injury. And after 72 hours, so the median of about 118 hours post arrest is the time which is actually taken into account. So assessing the motor response in the form of voluntary movements, whether it is to stimuli, there is no movement, or there is purposeful movement, and the status myoclonus, which is the 30 minutes of myoclonus, which actually carries a poor prognosis for these kind of patients. As far as the clinical neurophysiology is concerned, you have we take into account the EEG and the SSEP, and that is what we will see now. So EEG is electroencephalography, and it is a non-invasive neurophysiological technique which records the electrical activity in the brain through the electrodes which are placed on the scalp, and it monitors the brain activity in various conditions like seizures, coma, brain injury, and sleep disorders. So absence of EEG reactivity to the external stimuli is quite sensitive and highly specific for the poor prognosis. So this is the utility of the EEG, and we look at specifically at the burst suppression. And the other modality is the SSEP, or the somatosensory evoked potentials, which is a neurophysiological test that measures the electrical activity in response to the sensory stimulation. And the waveforms which are displayed on the computer screen, whereas the abnormal waveforms, as in this particular case, which will indicate the damage and the dysfunction along with the sensory pathways for that particular patient. As far as the sensitivity is concerned, the 50% which is post rewarming, and 25% in patients with therapeutic hypothermia. So this is what I had intended to just kind of throw a light on. Here probably we are stopping where we actually dealt with the neurophysiological studies, including the EEG and the SSEP. So that's all for now. In the next video we'll look at the biomarkers, and of course the cardiac biomarkers, and the how do we conclude about the prognostification of the CPCR patients. So that's all for now. Bye bye. Take care.